Hi, good evening. So today we're going to study about the use of azathioprine in dermatology. So let's start with the drug. Okay. Okay. So azathioprine has been synthesized from its parent drug 6-mercaptopurine. So during 1960s, 6-mercaptopurine. Let me just write it again. Yeah. 6-mercaptopurine was one of the very useful drugs during organ transplantation, and using this drug, azathioprine was synthesized. And azathioprine acts like a prodrug. That means inside the body, azathioprine gets converted back to 6-mercaptopurine, and subsequently 6-mercaptopurine leads to all the immunosuppressive action. So parent drug is 6-mercaptopurine leading to azathioprine, and azathioprine forms 6-MP inside the body. During 1960s, as azathioprine became the drug of choice for organ transplantation, predominantly used for kidney transplants. Okay, so kidney transplant is a very important indication for azathioprine. During the use of it as an anti-transplant rejection medication, it was noticed that it has significant anti-inflammatory properties, and that is predominantly due to its action on DNA incorporation of metabolites inside the DNA of immune cells, leading to immunosuppression. In dermatology, its major use lies in immunobullous disease, atopic dermatitis, actinic dermatitis, inflammatory and autoimmune dermatosis, but these are all non-FDA approved indications. Okay. Now, azathioprine is what is known as cycle-specific antimetabolite. That means it acts on a certain part of cell cycle during the division state, where it gets incorporated into DNA. And antimetabolite means it leads to decrease or inhibition of proliferation of cells. Okay, so azathioprine gets converted into 6-mercaptopurine, gets converted into 6-thioguanine, and this 6-thioguanine gets accumulated inside the cells, leading to toxicity. This 6-thioguanine incorporates itself into DNA or RNA of the cell, and which leads to cell death. 88% of the drug is absorbed when taken orally. The peak plasma level occurs within within the first 2 hours of intake orally. It does not cross the blood-brain barrier, but important point to note is that it crosses the placenta and also into the breast milk. So keep that in mind. It's the use of azathioprine has to be after significant consideration if you're using in pregnant or lactating females. 30% of the drug is protein bound, and we know that the free segment of the drug is responsible for its action. So if a patient has less protein less protein in the body, it will lead to more free drug and leading to more side effects. Half-life is 5 hours. Wolverton mentions 5 hours. Some book mentions 3 hours. A good range is 3 to 5 hours, but 5 hours is what Wolverton mentions. Empiric dosing is 2 to 2.5 2 to 2.5 or 3 mg per kg per day, and in certain cases, for example in TPMT deficiency or in patients taking xanthine oxidase inhibitors, you can, or in pediatric population, you can start with 0.5 mg per kg and gradually build it up, and you can easily go to 3 to 3.5 mg per kg per day. But the empiric dosing, as mentioned in Wolverton, is 2 to 2.5 mg per kg per day. Now the mechanism of action is that azathioprine gets converted into 6-thioguanine, and this guanine is the same guanine which is a purine. So we know that adenine and guanine are two purines which are responsible, along with their interaction with pyrimidines, which are thiouracil and cytosine. So with these are the natural purines in the body, and 6-thioguanine takes place of either one of them and incorporates inside the DNA or the RNA of the immune cells, leading to stoppage or inhibition of production of purine metabolism, also decreased proliferation of immune cells, leading to cell death, and that is responsible for its anti-inflammatory effect and the cytotoxic effects. With time, the 6-thioguanine slowly gets accumulated inside the cell, and this leads to a somewhat delayed onset of action, which is approximately 8 to 12 weeks. Okay, so we know that when we give azathioprine, it takes a certain time for it to reach its clinical efficacy, and then it stays there. So this time is roughly 8 to 12 weeks. In clinical practice, you can see the effect at 4 to 6 weeks, but 4 to 8, 12 weeks is a good enough range for the maximum clinical efficacy of azathioprine to start. Now we will just look at the structure of 6-mercaptopurine, the parent drug for azathioprine. So in this structure, these two rings that you are looking at, this is known as a purine backbone. Okay, the structure or the placement of double bonds might change from purine to purine, but this is what is known as purine backbone, and the elements or the bonds which are shown in blue are the bonds which are seen in 6-mercaptopurine. Now this was the parent drug, and using 6-mercaptopurine, azathioprine was created, which is responsible, sorry, in which we see an additional ring there, and this is the drug that we are studying right now. So if we see subsequent structures, azathioprine gets converted to 6-thioguanine. You can see the similarity in structure and also 6-thioguanine similarity to 6-mercaptopurine. Now, as I've mentioned that these two rings are the purine backbone, and these are the natural occurring purine. In guanine, you can see these two rings. In adenine, you can see these two rings. The only difference is that the amine group in adenine is replaced by a sulfur group or the thiol group in 6-thioguanine, or the hydroxyl group in guanine is replaced by sulfur group in 6-thioguanine. This similarity of structures between 6-TG and adenine or guanine is responsible for 6-TG taking their place in DNA, leading to DNA decrease in proliferation of the cells and also inhibition of purine metabolism. Let's go further. How it is metabolized after oral absorption. So I have told you that around 80 to 88% gets absorbed from the oral route. After absorption, it is rapidly and extensively metabolized in liver. One thing to mention is that most of the azathioprine gets metabolized. Just pardon my ridiculous handwriting. So most of the azathioprine is metabolized. A little bit is left, and that is excreted via kidneys. Okay, so kidneys are the organ of excretion. For metabolism, it's liver. And in the body, azathioprine gets converted into 6-mercaptopurine, which gets converted into 6-thioguanine, and this is responsible for your action. Now, remember somewhat this change in azathioprine to its subsequent metabolites, and you will remember number one, the mechanism of action, number two, side effects because of allopurinol, which is very important, and all the hullabaloo, all the discussion regarding thiopurine methyltransferase or TPMT. Here, I will only discuss about HGPRT pathway, xanthine oxidase, and TPMT. We will discuss a bit in detail towards the end. Okay. So here we can see that azathioprine gets converted into 6-mercaptopurine, and this conversion takes place in erythrocytes. Okay. So in erythrocytes, azathioprine changes to 6-mercaptopurine. There are also other sites of conversion, but the major conversion is through the erythrocytes. Okay. Now 6-mercaptopurine has three ways to go. Either it goes to the HGPRT pathway, or it goes towards the xanthine oxidase, or it goes towards TPMT pathway. Xanthine oxidase and TPMT will lead to inactive metabolites not responsible for function. These are going to get excreted. HGPRT pathway will lead to formation of 6-thioguanine, and that is the active metabolite. Okay. If we block these two enzymes, more azathioprine will be shuffled to HGPRT pathway. So if these two are blocked, excuse me. So if these two are blocked, more azathioprine will go towards HGPRT. There will be more 6-thioguanine, and more 6-thioguanine will lead to increased side effects or increased clinical effects and increased side effects of azathioprine. Okay, we'll just discuss about the HGPRT pathway here. We'll discuss the other pathways subsequently. Now, HGPRT pathway is the most common and the most of the azathioprine, most of the, let me just write it again. Most of the azathioprine gets shuttled through the HGPRT pathway, leading to formation of thioguanine. Okay, so this can be monothioguanine, dithioguanine, triphosphate. So thioguanine, monophosphate, diphosphate, triphosphate, all sorts of species are formed, but the major action is through thioguanine monophosphate. Okay, so let's go to the further slide. So as I had said that 6-thioguanine is a structural analog of adenine and guanine. These are the purines. 6-thioguanine has thiol group in place of amino and hydroxyl, which we have discussed previously when we were discussing the structure. Now what happens is 6-thioguanine replaces adenine and guanine inside the DNA and RNA of the cells, and this leads to either inhibition of purine metabolism and also inhibition of cell division. And because of inhibition of cell division, the inflammatory cells don't divide, they don't proliferate, and that this leads to immunomodulatory and anti-proliferative effects. So this is the major mechanism of action of azathioprine, that it gets converted into 6-TG. 6-TG, because it is similar to adenine and guanine, gets incorporated into RNA and DNA, and this leads to increased cell death. Okay. Additional mechanisms are that there is decrease in T cell function, specifically CD8 positive. That's what Wolverton mentioned. The CD8 positive cells, T cells, are significantly decreased. The function is decreased. Also, it decreases the antibody production via B cells. Okay, so both cell mediated and also humoral mediated immunity is suppressed by azathioprine. Additionally, IgM, IgG, interleukin 2, these are all inflammatory interleukin 2 is an inflammatory cytokine, is also decreased with azathioprine. Now, when we stop azathioprine, as we know that azathioprine takes some time to show its clinical efficacy, and when we stop it, it shows some time for the efficacy or the effect, the immunosuppressive effect to go away. So after stopping azathioprine, it takes around approximately 3 to 4 months for the azathioprine to go. Now, every one of us has our own specific or special immunosuppressant, non-steroidal immunosuppressant, and we would like to use one immunosuppressant in certain conditions. For example, I would like to use methotrexate in psoriasis, but if I want to use azathioprine, I might be not that much willing as I would have been if I would be using methotrexate. That is just because of the way I have been taught and the way that I have seen others prescribing during my residency. So whenever you want to use a drug which has a certain indication but you have not used previously in that indication, it's better to go towards these general guidelines. And in the context of azathioprine, we should always look that disease should be life-threatening. That means you have to treat it. The disease should be reversible or controllable. Do not use any immunosuppressive drugs when you know it is not going to have any major effect. It is unresponsive to potentially less toxic therapies. So if there are other options available which are less toxic than azathioprine, and the disease is not responsive to it, then you may consider using azathioprine. Okay. It should have measurable clinical or laboratory measures of improvement. That means we should know whether the drug is working or not. If we don't have any ways to know whether Azoran is working or not, then there's no point in using azathioprine. This is the most important point in my opinion, that all risk and benefits have been discussed with the patient. Keep the patient informed about what we are doing, what we are expecting, and what are the issues that might arise on a treatment. Alternative therapy should also be discussed with the patient. All options should be given, and the treatment has to be discussed. Okay, these, see, immunosuppressive drugs, be it steroids or be it non-steroidal immunosuppressives, they are important and powerful drugs. So we have to keep in mind that all decisions has to be taken after discussing with the patient, and the patient has no idea about these drugs or its efficacy. It's our job to decide for them, and it is always better to keep them in the loop so that we can have the maximum clinical efficacy while we are using the drug. Okay, so we should not take patient for granted, and we should make sure that they know exactly what we both together are getting into. Okay, now patients should be compliant with various laboratory monitoring tests. So subsequently we will discuss how to monitor patients on azathioprine, and the patient should be compliant. They should be willing to get regularly tested so that we may know if azoran is causing any kind of side effects. Okay, now let's see the indications of azathioprine. And as you can see that there are so many indications. So previously during methotrexate also I discussed that whenever you want to remember or memorize these kind of indications, you just have to memorize the headings, nothing more than that. Okay, so you would be thinking, okay, initially I had said that organ transplantation and severe rheumatoid arthritis are the only two FDA approved indications. All of other indications are off label, non FDA approved. Okay, so you will see two colored stars here. The orange color stars are the diseases in which the European societies has used azathioprine and they're okay with it. The green one are the Indian or the in Indian scenario where azathioprine has been used and found to be significantly effective. So there's one more drug. So just to recap, or just to recapitulate in just a single slide, that all these indications are there in which azathioprine has been used, and some of them indications are more in the European population, some of them more in Indian population. For example, immunobullous dermatosis like bullous pemphigoid, pemphigus vulgaris, vasculitis like LCV, Wegener's, polyarthritis nodosa, neutrophilic dermatosis like pyoderma gangrenosum, Behcet's, autoimmune disorders like lupus, DLE, dermatomyositis, dermatitis like contact dermatitis, atopic dermatitis, and I would like to add that Parthenium dermatitis and airborne contact dermatitis are also two indications which are much more important in Indian scenario, in which azathioprine has found to be significantly effective. Okay. In photodermatosis, it has been mentioned that in severe cases of photodermatosis not responsive to other therapy, azathioprine can be tried. Other miscellaneous are sarcoidosis, especially showing pulmonary features, or erythema multiforme, which is persistent. Hansen's, I think Wolverton likes to mention ENL in Hansen's, or lepra reactions. Vitiligo is one important indication. I've personally used during my residency a lot of azathioprine in vitiligo. This was subsequently after a thesis by one of my seniors. So azathioprine has shown to be a good non-steroidal maintenance agent in vitiligo. Okay, if you want to provide immunosuppressant effect for a prolonged duration, it's a good idea to use azathioprine as a maintenance agent. Okay. Now, one thing to remember is that in all of these indications, even if azathioprine is the first line agent, it should not be used as a agent to start remission. Okay, it should be the agent of choice to maintain remission, because we know that azathioprine is not a fast acting drug. It takes a certain amount of weeks for it to show its full effect. So it's better to maintain the remission. I would say achieve the remission first using drugs like systemic steroids, methotrexate, or MMF, cyclosporin, and then maintain that remission using azathioprine. We'll just discuss a few of non-FDA indications. For example, vasculitis. It is second line for cutaneous small vessel vasculitis after dapsone and colchicine. So these two drugs are first line, and after that, second line is azathioprine. In chronic and relapsing vasculitis, it is the first line immunosuppressant. In neutrophilic dermatosis, it has been found that eye effects, and we are speaking more in the context of Behcet's, eye symptoms show much more resolution as compared to skin, and mucosa have similar resolution. So it's much useful when ocular symptoms are predominantly present. In lupus like SLE, DLE, SCLE, lupus nephritis, or a person who's having significant palmoplantar involvement with DLE lesions, azathioprine can show good significantly effect. And most of these studies, most of these indications are in Western population. Indian population deals mainly with, as I've already mentioned, Parthenium dermatitis and ABCD. Okay. Now, I mentioned previously that chronic actinic dermatitis and PMLE in severe cases which is not responding to other drugs, azathioprine is a very good option. In dermatomyositis, the lung symptoms and muscle symptoms improve similarly, and there are much better improvements seen in these organs as compared to skin. Now, the major benefit of using azathioprine is its corticosteroid side effect sparing effect. That means it is a very good drug when you would want to spare the patient of all the steroid induced side effects. So it is said that when azathioprine is used more than 9 months in a patient, the side effects that you would have seen with other immunosuppressants and corticosteroid, compared to them, azathioprine has less side effects. And this corticosteroid sparing effect has found to be better than mycophenolate mofetil and comparable to cyclophosphamide. Okay, the only advantage is that these drugs are somewhat quicker acting as compared to azathioprine, and it's better to initiate remission using these two drugs and then maintain that using azathioprine. So azathioprine is a very good choice, but it is slow acting, so it's a good maintenance agent. And here I'll just mention liver mini therapy, and I'm mentioning it because I read about it. It is not that important, just out of curiosity. So liver mini therapy has been used in immunoblast disorders like bullous pemphigoid, pemphigus vulgaris, and it includes 40 milligram prednisolone to be taken on alternate days plus 100 milligram azathioprine every day (OD). So this is liver mini therapy. It is found to be significantly effective, that you initiate remission with prednisolone and maintain it with azathioprine. Now, after you have used azathioprine, what are the contraindications? So the absolute contraindications are to whether the patient is either hypersensitive to azathione, and hypersensitivity is an absolute contraindication to nearly all drugs. One exception is maybe penicillin, in which you desensitize and still give, but if hypersensitivity is there, it's better to avoid the drug altogether. The other contraindication is TPMT, or thiopurine methyltransferase deficiency, and we will discuss that in detail in towards the end of the presentation. So these are the Western population data. And what is homozygous or heterozygous? So I'll just discuss that in the end. But you could say that 0.3% of Caucasians are homozygous, and in those homozygous, the dose has to be decreased by dividing it by 10. Okay, while 10% Caucasians are heterozygous, and the dose has to be divided by either you divide the dose to its 1/3 level or 1/7 level. Till 1/7 level you may have to divide if you're dealing with heterozygous variant in Caucasians. So these are all Caucasian data. I'll discuss in brief the Indian data at the end. Now these are some contraindications, and these are all relative contraindications. So hypersensitivity to azuran we have discussed as an absolute contraindication. Box warnings are against post-transplant NHL. Now non-Hodgkin lymphoma is one of those lymphomas which might arise in the background of azathioprine induced immunosuppression. So the box warning says that in patient with NHL, it's better not to use. Okay, so we'll discuss while we'll discussing side effects. So warnings and precautions are infections. You just have to remember the heading: liver, infections, and blood and GI. Okay, so infections has opportunistic infections like bacterial, viral, fungal, protozoal. Potential reactivation of latent infections like TB, which becomes very important in the Indian scenario. Hepatitis B virus. Now, JC virus is John Cunningham virus, and this leads to, as far as I know, JC virus is present in roughly 40 to 50% of population. and in immunosuppressant by azathioprine, it can lead to its activation, leading to progressive multifocal leukoencephalopathy. Leukoencephalopathy. That's how I pronounce it. So it's progressive multifocal leukoencephalopathy. Now, immune response to vaccines, live attenuated vaccines can have reactivation of viral particles, especially in live vaccines, and subunit vaccines can have a little bit of attenuated or decreased response because the immunity is suppressed by azathioprine. Okay. Now, malignancy, that means non-melanoma skin cancers, and there has been a subsequent theoretical risk of increased chances of squamous cell carcinoma in patients with azathioprine. So that has to be kept in mind. Isolated liver toxicity is possible, and predominantly it is shown by increased SGOT, SGPT. The blood parameters are deranged, leading to dose-related leukopenia, decrease in blood counts, predominantly TLC, decrease in neutrophils, decrease in hemoglobin, and if all three lines are involved, WBC, platelets, and hemoglobin, it is pancytopenia. So TPMT, how to use TPMT levels to guide your dosing, we'll discuss when we are discussing TPMT. Now, hypersensitivity syndrome to azathioprine is somewhat like a drug reaction, but it has been described as distinct from DRESS. Okay, so DRESS is a different entity altogether, although that is also caused by a drug, by any drug. But this drug hypersensitivity to azathioprine is different in presentation as compared to DRESS. Okay, so we'll discuss that in the next slide, I think. The GI symptoms include diarrhea. There are also subsequent symptoms like fever, exanthem, hypotension. I think these are all the symptoms which are seen in drug hypersensitivity to azathioprine. GI like nausea, vomiting, the general side effects that we have to mention, the most common ones. Now, pregnancy prescribing status is that initially it was measured as category D, but now after 2015 we are not using it. So in the second trimester it is low risk, and when female is in the third trimester, the risk increases to moderate to high risk. Okay, so this is the current classification of azathioprine. It is moderate to high risk in third trimester. Now let's see the adverse effects in detail. The GI adverse effect is the most common adverse effect, predominantly nausea, vomiting, diarrhea, and very rarely pancreatitis. Mostly it is seen in the first to 10th day, that is initial 1 to 1.5 week of therapy. And the way to circumvent this, the way to prevent it, you would either decrease the dose, or you divide the dose over the whole day, or you take with food. Okay, so it's better to consult the patient that you may have this kind of issues. Now, hepatic adverse effect is predominantly transaminitis, and you can just look at the SGOT, SGPT levels if they are rising, and if the parameter that I use is if it rises more than 3 times the upper limit, I stop azathioprine. If it rises between the 2 times the upper limit to 3 times the upper limit, I decrease the dose in half. And if it is less than 2 times the upper limit, I just continue the drug and observe with regular monitoring. Okay, but that's my personal monitoring thing. Now, malignancy, the risk of malignancy, as we have previously discussed in non-Hodgkin B-cell lymphomas, and non-Hodgkin lymphomas, B-cell lymphomas, SCCs, and Epstein-Barr virus-induced lymphomas. So these kinds of incidents. Now you have to remember that B-cell lymphomas and virus-induced lymphomas, these occur because the uncontrolled proliferation of cells is not checked by immunity. And why is it not checked by immunity? Because we are suppressing the immunity using azathioprine. So whenever an immunosuppressant is used, be it azathioprine, be it methotrexate, you will see that EBV and B-cell lymphomas are at an increased risk, and these lymphomas regress when you stop immunosuppressive therapy. So remember that these kind of lymphomas can arise in a background of prolonged immunosuppression, and this is because the immune checkpoints are suppressed by the drug that you are giving. Squamous cell carcinoma is a theoretical risk. Literature mentions it. It is one of the box warnings also. But the incidence of increased SCC, now the doses which is usually used post organ transplantation or in cases of severe arthritis is a bit higher dose. It starts from 100 milligram a day, going as high as 150 to 200 milligram a day, and those patients have been shown to develop SCCs. The doses that we use in in dermatosis is a bit on the lower side. The average dose or the highest dose is around 100 milligram a day, not more than that. But that doesn't mean that you may not see these kind of lymphomas or non-melanoma skin cancers in skin patients. It is always better to have a lookout and perform full body examination during regular follow-up visits, maybe 3 monthly examinations, to look for suspicious lesions which might be initial stages of SCC. Okay, now this side effects, predominantly SCC, occurs because of either photosensitization, predominantly of the drug inside the cells, and also we remember that the mechanism of action is the increased accumulation of 6-thioguanine inside DNA. And in DNA, if there's anything else apart from adenine and guanine, that is a wrong purine there, and this leads to DNA mutation, and a mutated cell makes it more prone to SCCs. Okay, now these side effects are usually seen with prolonged duration of use, most commonly if more than 1 year it has been used, and it normalizes the risk for developing malignancy in patients taking azathioprine normalizes after the drug is stopped. Okay, but even after decreasing, let's say this is the baseline risk of developing any cancers, and you give azathioprine here, it will slowly increase, and when you stop it decreases, but it will still going to remain higher than baseline. Okay, so the lower value will still remain higher than normal. It will never touch normal, or it doesn't touch normal. Now the risk also increases if you're using anti TNF alpha, the TNF alpha inhibitors, predominantly in psoriasis or other disorders, or if the patient is more than 50 years of age, or also when you're using other immunosuppressant concurrently, like methotrexate or cyclosporine. Now, myelosuppression is the one of the first issues to crop up when you give azathioprine in patients who have subnormal levels of thiopurine methyltransferase, and it is mentioned that hemoglobin less than 10, TLC less than 3500, platelets less than 1 lakh, you stop the drug. Okay, so these are the parameters which will point you towards either one of the cell line penias or pancytopenia, and that's a very good indication to stop the drug. And to make sure you are on the lookout, continuous monitoring of CBC, complete blood count, is essential. Increased chances of infections are there when you're using multiple drugs or higher doses of azuran is used. Now, in vaccines, remember that live vaccines can show reactivation. It's better to give those live vaccines before 1 month of starting azathioprine. That means the gap between live vaccines initially followed by azathioprine should be more than 1 week. The other type of vaccines, including live vaccines, subunit vaccines, may show an attenuated response because the immunity is not working optimally. In pregnancy, I've already mentioned that the category is D, which is the older, and newer is moderate to high risk in third trimester, and it has been linked to low birth weight and prematurity in patients who were taking azuran during pregnancy. Now the risk to fetus is not that much because fetal liver lacks inositol phosphorylase, and this enzyme is essential to conversion of azathioprine to 6-mercaptopurine. Since fetal liver doesn't have that enzyme, the conversion to azathioprine to 6-mercaptopurine does not happen. And whatever azathioprine, remember that azathioprine crosses placenta, it crosses it crosses in the breast milk. So if we're talking about fetus, during the crossover through the placenta, when azuran reaches fetal liver, it is not able to convert into 6-mercaptopurine because the essential enzyme of inositol phosphorylase is absent. Now in lactation, 6-mercaptopurine is present in breast milk, but the level is minimal. So it is better to avoid azathioprine in lactating mothers. But if you have to still give it, Wolverton mentions you wait for 4 hours after intake, because maximum level of azathioprine in the circulation is during those 4 hours. If you remember, the half-life is 3 to 5 hours of azathioprine. And also it is mentioned that maximum dissemination of azathioprine through the breast milk happens in the initial 4 hours. So it's better, if you still have to give azathioprine in lactating mothers, it's better to advise them to wait for 4 hours after intake of medication to feed the child. But as we know that feeding is not, that regular. So I don't know how this would happen, that you will have a gap of 4 hours, so it's better to avoid. Now let's discuss about drug hypersensitivity. It is a hypersensitivity reaction which is distinct from DRESS. It occurs very quickly within the first 2 weeks of therapy. The range is around 1 to 4 weeks. It is characterized by cardiovascular collapse, fever, leukocytosis, GI discomfort with nausea, vomiting, intense arthralgia, myalgia, headaches, cough, and pneumonitis. The skin manifestations are protean. Protean means all sorts of morphologies are seen. Okay, protean means a lot of morphologies. So papules, macules, pustules, bulla, vesicles, morbilliform rash, all sorts of rashes have been described with azathioprine-induced drug hypersensitivity. So everything can be seen. The risk of drug hypersensitivity is usually increased when it is given concurrently with cyclosporin and methotrexate, and re-challenge is prohibited. You should not re-challenge a patient with azathioprine who has a history of drug hypersensitivity reaction with azathioprine. It can be life-threatening. So this is one of the areas where it is not supposed to be re-challenged if a patient has previously suffered from azathioprine-induced hypersensitivity. Now, some of the drug interactions which are very important, we will discuss allopurinol towards the end. It decreases the level of warfarin. So azathioprine may decrease the anticoagulant effect of warfarin, and a higher dose of warfarin might be required in patients who are taking this drug. And if the drug dose is not increased, so the decrease in the effect of warfarin because of azathioprine may lead to an increased risk of stroke and thromboembolic effects. So understand that if your patient is taking warfarin and you start azathioprine, the effect of warfarin will decrease. That will lead to increased risk of stroke and other thromboembolic events, and it's better to increase the dose of warfarin while the patient is taking azathioprine. Other TNF alpha inhibitors, we have previously described that the incidence of lymphomas are increased. Other folate inhibitors like methotrexate or cotrimoxazole and dapsone increases the myelosuppressive effect of azathioprine. So combination of these all drugs may increase the myelosuppression which is caused by azathioprine. Now, all sorts of immunosuppressants, if they're used with azathioprine, may lead to increased myelosuppression, increased immunosuppression, increased chances of lymphomas, increased chances of infections. So we need to keep that in mind, that you are not using multiple immunosuppressants in one patient. ACE inhibitors may potentiate leukocytopenia. Okay, so decrease in WBC count, which is also seen in azathioprine, can be seen when it is combined with ACE inhibitors. It's always a good idea to take a good drug history when you're using any drug, especially immunosuppressant, and mention that in the card. Okay. Now, vaccines like Zostavax, that is herpes zoster virus vaccine. This one is older. Newer vaccines like Shingrix, it has just been launched, I think, 2 to 3 days back, 1st of March, or it will be launched in April. So Shingrix is a new vaccine. Response to all of these vaccines are decreased, attenuated, and in cases of live vaccines, it may lead to reactivation of symptoms. Okay, so we see that Zostavax leads to increased risk of disseminated zoster. Shingrix is, I think it's a subunit vaccine, so the response might be decreased to Shingrix, But Zostavax is a live vaccine, so it might lead to a disseminated zoster infection. Sulfasalazine may decrease TPMT level, and decreased TPMT level will lead to a havoc with azathioprine. Okay, so after all indications, contraindications, ruling out all drug interactions, you plan to start azathioprine. These are the monitoring guidelines. Number one, during baseline, you discuss the risk profile, the benefit profile with the patient, and the serious and the most common adverse effects. You discuss alternative treatments and requirement of multiple blood investigations. The patient has to be compliant with repeated monitoring investigations. We have discussed that previously. Discuss sun avoidance, that is predominantly protection to non-melanoma skin cancers. Birth control and abstinence, because we know it's in category D with moderate to high risk in third trimester. So that has to be mentioned if you're using it in females of reproductive potential. Elicit history of concurrent drug use, mainly immunosuppressant and allopurinol or febuxostat. And physical exam with focus on skin and lymphoreticular, because we know that lymphomas might increase, and also SCC. So make sure you do a good thorough examination. I know we don't do usually, but please do it. Now, pregnancy test, CBC, serum chemistry profile with good focus on LFT and KFTs. Urine analysis test for proper kidney function. You know that all excretion takes place through kidneys. Tuberculin skin test is important in India, such an endemic country. Before starting any immunosuppressant, get a Monto done, get a chest X-ray done. Rope in a pulmonologist if you suspect TB. It's always better to be sure than sorry. Now, TPMT we'll discuss in detail towards the end, so I'm skipping that. So, during follow up examinations, you have to complete the clinical evaluation, including screening for SCC and lymphomas. Laboratory is bi-weekly for the first 2 months. That means 0 week, 2 week, 4 week, 6 week, 8 week, and then every 2 to 3 months. And that includes CBC with differential WBC count, LFTs to be focused more on SGOT, SGPT. Okay. Additional information. You don't need to repeat TPMT essays. We'll discuss that while we are discussing TPMT. Single point determination is enough. And it's a good idea in the absence of TPMT to keep your eyes open regarding blood parameters, predominantly leukocytosis, leukocytopenia, and pointers towards myelosuppression, and also rising SGOT, SGPT levels. That is a very good, you could say, surrogate marker of azathioprine toxicity. Now, we have finished the discussion about azathioprine. There's not much left. We'll just discuss about subsequent pathways through xanthine oxidase and thiopurine methyltransferase. These are majorly asked in Viva at resident level, but when you're practicing clinician, you need to know about these mechanisms, so that you need to ask about number one, any allopurinol or febuxostat intake, and regarding if you want or if it is necessary to do TPMT or not. Okay, so let's start with the middle parameters. So we know that azathioprine gets converted into erythrocytes to 6-mercaptopurine, and predominantly this goes through the HGPRT pathway, and this is the main pathway and main mechanism of action through 6-TG. Okay, some of the azathioprine gets through xanthine oxidase and gets converted into inactive metabolites. I don't remember exactly, but I think it's 6-thiouracil. I'll just have to check. So this inactive metabolites do not cause any kind of immunosuppressant. But if you're on a drug which is known as allopurinol, usually used when there is high uric acid, xanthine oxidase is an enzyme for uric acid metabolism. So a patient who is on gout might be taking allopurinol, or febuxostat is another drug. febuxostat. And xanthine oxidase, if it is inhibited, that means this pathway is now over. The AZA or azathioprine cannot go to this pathway, and it will be shunted more towards HGPRT pathway. And HGPRT pathway will lead to more 6-TG formation, and it will lead to more effects and subsequently side effects like life-threatening myelosuppressant or increased chances of infection, disseminated infection, or hepatic damage. So make sure that your patient is not taking allopurinol or any other kind of xanthine oxidase inhibitors, so that it doesn't push azathioprine towards the HGPRT pathway. Okay. Now, xanthine oxidase leads to formation of inactive metabolites, and if a patient is on allopurinol, a good idea is to either the good idea is not to use azathioprine. If you really want to use azathioprine, a good idea is to reduce the dose by 75%. Use only minimal dose, because major will be shunted towards the HGPRT pathway. So, so decrease the dose of azathioprine so that most of it goes to the HGPRT pathway, and you do not land up in increased dose related myelosuppressant. Okay. Just a side note that HGPRT mutation is seen in Leishman syndrome, and Leishman syndrome is characterized by self-mutilation and self-harm behavior. And if HGPRT is not working, then most of the azuran you're going to give is converted into inactive metabolites. So of course you need to know about all this. Okay, so we have finished with azathioprine general considerations. We have discussed the use of allopurinol and febuxostat and what interaction it has with azathioprine. Now, I think this is the last part of the presentation in which we will discuss the one of the hot topics, TPMT, thiopurine methyltransferase. Now, thiopurine methyltransferase is one of the three mechanisms by which 6-mercaptopurine is metabolized into its inactive metabolites. Okay, so as thiopurine becomes 6-mercaptopurine in erythrocytes, the 6-mercaptopurine gets converted to its inactive metabolites in TPMT. If TPMT is either decreased or it's not working, more of the azathioprine will be shifted to HGPRT pathway. This will lead to increased thioguanine, and this will lead to side effects. Okay, so this is the basic understanding. If TPMT is not working, more 6MP to the HGPRT pathway, more 6TG, more side effects. Clear? Now we'll just discuss some points about TPMT. Whenever we are looking for mutations in TPMT, there are two types we have to discuss. One is genetic, other is phenotypic. Genetic means whether the genes are working or not. There are three types. So these are the two alleles. If both of the alleles are normal, this is known as homozygous wild type. If both of the alleles are mutated, this is known as homozygous mutant type. And if one allele is mutated and the other allele is normal, this is known as heterozygous wild type. A good thing to remember is homo means same. So normal is wild type because that is the normal arrangement in majority of population. If both of them are mutated, then it is homozygous mutant type. If one of them is mutated, other is normal, it's heterozygous, that means different, hetero, wild type. Okay. Majorly when we test for TPMT, we are looking at the genetic polymorphisms. That means we are looking at the genes which encode for TPMT and whether the patient has a wild type or a heterozygous wild type or a homozygous mutant type. That is what we are checking. Okay. If you have a heterozygous wild type, sorry, let me just start it again. First scenario is homozygous wild type. This is the most common polymorphism seen in around 95% of general population, In this, the enzyme level is high or normal. Okay, in these kind of patients, you don't have to do anything. Use the regular doses of azathioprine, it will be okay. Second scenario is homozygous mutant, in which both the alleles are not working, and this is seen in very rare percentages ranging from 0.3 to 0.06%. Just a second. 0.06%. Okay. This is known as low activity of TPMT, and in this patient, azathioprine is contraindicated. You cannot use azathioprine. Okay. If you have to use it, the dose has to be decreased till 1/10 of the normal doses, but it's better not to use it. And it is in very low, less than 1% of general population has this polymorphism. The middle one, which is known as heterozygous wild type, in which one is normal allele and other is mutant allele, is seen as roughly 5% of population. This is known as intermediate activity of the enzyme, and in this you have to decrease the dose either to its 1/3 level or 1/7 level. Okay. Now the other viva question comes is that what is the prevalence of TPMT mutation, and I'm talking about the homozygous mutation in Indian population. So in Indian population, it's roughly, as per an article that I read, it was roughly 0.06%. So that is the lower limit of the range. But you would not be wrong if you say it ranges from 0.3 to 0.06%, or less than 1% have this homozygous mutant gene. Okay, clear, Savi? There are different types of mutations mentioned. These are just for theoretical knowledge. 3A, 3B, 3C, 2. These are the most common mutation, accounting for more than 95% of mutation. Other important point regarding TPMT mutation is that it is transmitted as an autosomal dominant trait. So it's a good idea to see the pedigree if you're not that sure. In 2/3 of the cases, the decrease in TPMT values because of genetic mutation or defect. Okay. Issue arises that what happens in the rest 1/3 of the cases. In rest 1/3, other factors like environment factors or post-translational modifications or the activity of enzyme at the site decides whether its activity will be optimal or suboptimal. So that means that in not all cases of genetic polymorphisms, uh, for example, on genetic testing, you would have normal alleles, but the patient is responding as if the TPMT is not active. That means post-translational modifications are happening, which is seen in 1/3 of cases. Okay, remember that in India or anywhere else, the most common testing. Let me just change this. Yeah, the most common way to test TPMT levels is genetic. So we just look at the genes, whether it is mutant or wild type. We don't look at the phenotypic testing. So you have to just keep that in mind, that even a normal genetic profile can lead to suboptimal level and activity of TPMT. Clear? Other points are, one of the important point is that if increased side effects are occurring because of TPMT decreased activity, it takes around 4 to 10 weeks to show its effect. Remember how azathioprine acts. Azathioprine gets converted to 6-mercaptopurine, gets converted into 6-thioguanine, which gets accumulated in cells, leading to toxicity. This takes some amount of time. The onset of action is roughly about 4 to 6 weeks. Books mention 8 to 12 weeks. That means it takes some amount of time for 6-thioguanine to accumulate. If TPMT is not working, the accumulation is increased. So instead of 8 to 12 weeks, it is now happening in 4 to 10 weeks. So it's a bit delayed. Contrast that to drug hypersensitivity reaction, which occurs in less than 2 weeks. Drug hypersensitivity is quicker to act, while increased side effects because of TPMT deficiency or suboptimal action takes around 4 to 10 weeks. That means if you give azathioprine to your patient and it leads to leukocytosis within a week or increased OTPTs within a week, Most likely it's because of hypersensitivity and not any derangement of TPMT levels. If it takes some time, after 1 month you're showing the same side effects, it can be because of TPMT. Okay. Now another question which is usually asked in Viva is, would you like to get TPMT levels for your patient? A good answer, or how to answer in Viva, is point number one. Would you like to do? Yes, of course. Guidelines mention you have to get it done TPMT. Second point, but if TPMT levels are not available, or it's not available in markets or laboratories, would you still give azathioprine or not? The answer would be yes. If the patient is satisfying all the indications for azathioprine and other drugs cannot be given, and I would really like to give azathioprine and TPMT levels are not available, we can give. Reason for that is, number one, we are just looking at genetic polymorphism, not phenotypic polymorphism. Number one. Number two, 95% have the wild type, that means they will have normal levels. Add it 5%, that means nearly 100% population will have wild or intermediate acting TPMT level, and they will be okay with lower doses. So you may start azathioprine with lower doses, leading to uh, if you have any kind of side effects, you'll be able to see in subsequent monitoring. Less than 1%. Third point is that TPMT mutation or homozygous mutation is seen in less than 1% of patients, specifically 0.3 to 0.06%, in which azathioprine is absolutely contraindicated, and that's a rarity. But that I'm talking whether when you're not able to get TPMT levels. So, is it essential to get TPMT levels in all patients? Not necessarily. You can start with a low dose and see the blood parameters of subsequent visits whether any derangement is happening or not. Okay. Apart from that, if it's the facility is available and the patient is affording, get it done. Other point that is asked in Viva is, what is the cost? Cost range is around, as of 2022 to 2023, around 5,000 to 8,000, and you need to get it done only once. There's no point in repeating this test. It doesn't have that value. You need to do it before starting azathioprine. Okay, nearly all famous or all significant labs have the facility to get this thing tested. Remember that azathioprine is a post organ transplant drug, so nearly every lab has its facility to measure levels. It cost is around 5 to 6,000 starting range and ends in 7 to 8,000. Okay. Now this, I think, is the last slide of the presentation. Drug dosing by TPMT level. Let's say you get TPMT level done, then what? So normal TPMT levels or good TPMT levels lie between 15 to 26 approximately. So if it is between 15 to 26, that means you have high TPMT activity and you can go with the empiric normal dosing of 2 to 2.5 milligram per kg per day. If you have less than 6.3, no azoran. Remember, less than 6.3, no azathioprine. Less than 6.3 is known as homozygous mutant type. It leads to low TPMT activity. You cannot use azathioprine in that patient. It will be very, very problematic. If it's in between, that is in between 6.3 to 15, you have medium level of TPMT or the intermediate level. The dose has to be half. So from 2, it becomes 1 mg per kg. And this will lead to significant immunosuppressant effects. And it's better to maybe start half the dose, like 0.5 mg per kg, and gradually increase to 1 mg per kg, so that we may able to look at any kind of derangements that may happen in a patient taking azathioprine. So if you get TPMT levels done, you may change the doses of azathioprine to use. If the TPMT levels are normal and you would like to increase the dose, you can go as high as 3 to 4 mg per kg or 3 to 3.5 mg per kg. 50 milligram TDS 3 times a day will work wonders if the patient is not having side effects and if the patient's disease is responding to increased dose of azathioprine. Clear? So with this, I would end my presentation on the use of azathioprine in dermatology. If you have any kind of doubts, suggestions, any clarifications, queries, just mention them in the comments. I'll reply them as soon as possible. You can also email me and come in contact anyways through WhatsApp or anything. If you have come across different type of questions that you have been asked in your Viva, let me know. If there are any other clarifications, any newer things that you would like to know about azathioprine, that you have no clue what the answer is, it's better to ask so that I may also learn newer things about this drug. And with time and subsequent usage, we become much more comfortable in using azathioprine dermatology. Okay, with that, thank you.